Joining us for the webinar, the Behavioral Health Needs Framework and Collaborative Comprehensive Case Plans. My name is Mark Stovall, and I'm a Senior Policy Analyst here at the Council of State Governments Justice Center, and I will be moderating today's webinar. We have a great list of panelists joining me today, and I'm going to read brief biographies for each of the panelists. Donna Bond is a licensed professional counselor and serves as the coordinator for mental health reentry with the Oklahoma Department of Corrections. Starting her career in 1999 with the Department of Corrections, along with 9 Oklahoma Department of Mental Health and Substance Abuse Services staff inside DOC facilities managing mental health reentry programs and federal grants, Donna has over 20 years experience working with both co-occurring and seriously mental ill diagnosed populations within the DOC. David DeMora is a Senior Policy Advisor to multiple projects at the Council of State Governments Justice Center in New York City. A 40-year veteran of working at the intersection of behavioral health and criminal justice, David has provided training to therapists, probation and parole officers, prosecutors, defense attorneys, judges, and public officials in 48 states and 3 countries. He is the author of Adults with Behavioral Health Needs Under Correctional Supervision, a shared framework for reducing recidivism and promoting recovery, which he will talk more about on the webinar today. And most recently, the co-author of a 5-level risk and need system, maximizing assessment results in corrections through the development of a common language. And we also have Whitney Johnson, who is a case manager for the intensive outpatient programs through the Douglas County Community Mental Health Center in Nebraska. She began her career in the Community Mental Health Center Psychiatric Outpatient Clinic 8 years ago and transitioned over to intensive outpatient programs at corrections 4 years ago. Her current role is the highlight of her career because it demonstrates the impact that innovative collaboration has on the community's high-risk, high-needs clients. And thank you all for joining us today. To give you an overview of today's webinar, first we'll do some introductions of the Justice Center and the National Reentry Resource Center, and then you'll learn more about the Behavioral Health Needs Framework and Collaborative Comprehensive Case Plans. Then we'll hear from Whitney in Douglas County, Nebraska, and Donna in Oklahoma about the case planning processes in their programs, which focused on pretrial diversion and prisoner reentry, respectively. And at the end of the webinar, we'll have some time for questions and answers. And before I move on, I want to note a few housekeeping items. Anytime during the webinar, you can ask a question by typing it into the QA panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go, and for the content-related questions, we'll keep a running list and address them all at the end of the webinar, or as many as we can. We'll do our best to get through as many questions as possible within the time. If you encounter technical or audio problems during the webinar, you can call WebEx technical support at 1-866-229-3239. We are also recording the webinar, and we will post it on the National Reentry Resource Center website within a week. And now I'm going to do some introductions to the Council of State Governments Justice Center and the National Reentry Resource Center. The Justice Center is a national nonprofit, nonpartisan organization that serves all 3 branches of state government. And at the Justice Center, we focus on criminal justice, and we develop research-driven strategies to increase public safety and strengthen community. The Bureau of Justice Assistance, or BJA, is the funder of this work, including this webinar, and you can see their mission statement on this slide. The Justice Center operates the National Reentry Resource Center, or NRRC, in partnership with BJA. And this allows us to provide technical assistance to grantees like many who are attending the webinar today, and also provide broad-based support to the field. We advance the knowledge base on what works in reentry, promote grantee successes, facilitate peer networks, and give information to people who are returning to their communities after incarceration. And here you can see a bit more about what the NRC does, including disseminating the latest news and resources in reentry, and maintaining the National Criminal Justice Initiatives map and directories for state and local reentry services. The Second Chance Act, which was passed in 2008, supports units of government in reducing recidivism and improving outcomes for people leaving incarceration and returning to their communities. The Second Chance Act has supported over $400 million in reentry investments across the country, and in 2018, the Second Chance Act was reauthorized to strengthen the initial legislation. On this slide, you can see the reach of the Second Chance Act, specifically the Reentry Program for adults with co-occurring substance abuse and mental illnesses, or CSAMI for short, which has provided over $61 million in funding to 47 county grantees, 25 state grantees, and 6 tribal grantees. And in this grant track, there have been 105 awards across 26 states, the District of Columbia, and 1 territory. The purpose of the Second Chance Act CSAMI grant program is to enhance the ability of correction systems to address the needs of people with co-occurring substance addiction and mental illness in order to reduce recidivism and improve public safety and public health. This program provides funding for entities to implement standardized screening for co-occurring disorders in correctional facilities using validated tools, providing assessment for those who screen positive for co-occurring disorders, and assessing them for criminogenic risk or their likelihood to reoffend, provide pre- and post-release services for addressing behavioral health needs and criminogenic risk, develop and implement collaborative comprehensive case plans that incorporate information from criminogenic risk and behavioral health assessments, and create a performance measurement plan that outlines who is responsible for data collection, input, analysis, including identifying and working with a third-party evaluator. And as you've heard me mention a few times, a recurring theme in this grant track is addressing criminogenic risk and needs and behavioral health needs. And the NRC's work with CSAMI grantees over the years has helped inform the work that we do for developing products and tools to advance the field. We've seen the successes and challenges that grantees face in addressing these issues in their grant programs, and we respond by disseminating best practices and helpful grantee examples to help drive the use of evidence-based practices. And we're going to talk about more about 2 of these products and tools in particular, starting with the Behavioral Health Needs Framework, which I will turn over to David Demore to discuss. But first, we have a quick poll for the attendees on the webinar today. And so the question is, what type of agency do you represent? And the options are behavioral health treatment provider, community supervision, corrections, court, social service agency, or other. So go ahead and take about 20 seconds to select which agency you represent, and then we'll get a sense of the results in a minute. And we're waiting for WebEx to tabulate the results quickly for us so we can get a display of who is represented among these different agencies. All right, so there in the bottom right-hand corner of the screen, we can see the results from the poll. So it looks like a pretty even mix, which is pretty much what we had expected. And it's always great to see and to know who we're talking to as we do this presentation. And thank you all for typing in which agency you represent. So now I will turn things over to David Demore to discuss the criminogenic risk and behavioral health needs framework.
Thanks very much, Mark. Good afternoon, everybody. I'm pleased to be able to spend some time with you this afternoon and talk about the criminogenic risk and behavioral health needs framework. The framework is something that we developed several years ago as we began to realize the need to better think about how to integrate behavioral health needs and criminogenic risk. In terms of talking with you all about this, what I'm going to do is I'm going to discuss some issues related to behavioral health, some issues related to criminogenic risk, and then how that has all sort of flowed into the development of the framework. I fully realize that many of you will know different parts and perhaps many parts of what I will talk about, but what we want to be sure of is two things. One is we want to make sure that everybody's on the same page in terms of language and thinking about how it is that we arrived at the results that we did for the framework. And secondly, we wanted to be able to clearly explain how we got to our thinking about the framework. So as I talk about some of this again, I suspect that some, if not many of you, will know different pieces of this, fully understand that, and I don't want to make believe that you don't. But again, we do want to be certain that we are all sort of on a level playing field, if you will. When we look at folks who have behavioral health needs, in other words, mental illness or substance addiction needs that are in the criminal justice system, we find some interesting things that are very concerning, quite frankly. First of all, they tend to be arrested at higher rates than the general population. Many of them often have limited access to health care. They typically have longer stays in jail and prison, particularly in jails. They have high recidivism rates, not necessarily due to criminogenic factors all of the time, sometimes because of their mental health issues. But many of them also have more criminogenic risk factors that need to be ameliorated. One of the things that is interesting is that we often talk about folks with behavioral health needs as if they're sort of a subset of the people that we see in our system. But in fact, they tend to be a very large portion of people that we see in our system. And rather than think of them as a subgroup that we should be looking at, it really makes a lot more sense to think of them as a major portion of our population, and that when we meet anybody who's coming into the criminal justice system, we need to always be thinking about what potential behavioral health needs may exist. So we talked a little bit about mental health needs. We talked a little bit about substance use needs in terms of talking about behavioral health. And of course, there's the issue of co-occurring substance use and mental illness together. People are said to have co-occurring needs when at least one disorder of each type can be established independently of the other, and it's not simply a cluster of symptoms resulting from a single disorder. Once again, we see a very large number of individuals in the criminal justice system who have co-occurring disorders, and we as a system often do not respond very well to those folks. While it is true that a good number of those folks may come in because of a criminal behavior or a criminogenic need that I'll talk about in a little while, one of the things that unfortunately happens is that they end up becoming trapped in the system because of the behavioral health need, not because of their level of criminogenic risk. When we compare the folks, when we compare the issue of illicit drug use and substance use disorders, and we compare that to the general population, we find that people on probation and parole have much higher rates of substance use disorders. And what's really interesting about this particular slide is not only are the rates higher in terms of illicit drug use, but the rates are so much higher in terms of substance use disorder. When you go down to the general population, you see there's actually a slightly larger amount of illicit drug use than there is substance use disorder. But when you go up to looking at folks who are on probation and parole, you see that, yes, there's more illicit drug use, but there's also more substance use disorder when we look at those folks. They have more stressors, they have more difficulties, they have more problems that are related to their drug use and to just generally problems of living. Parenthetically, the expectation that these folks with greater substance use disorder connected to their illicit drug use will just suddenly stop when we get them on supervision and will do so quickly actually isn't very logical. We need to think about the difference between the short-term accomplishments that can be done and what the long-term goal of supervision of these folks is in terms of lessening or stopping their drug use over time. When we look at the issue of substance use disorders in terms of alcohol and substance use disorders, looking Comparing that to the general population versus jail and prison, we find once again that those folks that are in jail and prison have higher rates of substance use and alcohol disorders. And again, you can see strikingly different rates and strikingly higher rates compared to the general population. And then when we look at the issue of co-occurring substance use disorders and serious mental illnesses, once again, what we can see is that folks in the criminal justice system have higher rates of co-occurring substance use disorders and mental illnesses compared to the general population. And you can see here the increase in jail, the increase in prison, the increase in probation and parole as compared to the general population. Despite what I have just said about the fact of the matter being that we have much higher rates of substance use disorder, of mental illness, of co-occurring disorders, of folks who are in the criminal justice system, it is important to understand that for many of them, that is not the only thing that exists, and it may not be the direct thing that brought them to the system. A good number of folks with behavioral health needs also have as many or slightly more criminogenic risk factors as compared to those folks who don't have mental illnesses who are in the criminal justice system. Or in other words, they have sort of a triple whammy. They have the difficulties in terms of behavioral health, possibly co-occurring disorders, and the difficulties in terms of what we call criminogenic risk factors or criminal thinking. Criminogenic risk is the likelihood that a person in the criminal justice system will commit a new crime or will violate the conditions of their supervision. It's important to understand that criminogenic risk is not the type of crime. It is not failure to appear. That is a completely different issue. It is not the sentence that somebody is given. It is not a custody or security classification level, and it is not assessing dangerousness. There are other ways to look at failure to appear. There are other ways to look at classification levels. There are other ways to look at dangerousness. But when we talk about criminogenic risk, we are strictly talking about the potential of somebody to commit new crime or to violate the conditions of their supervision. To reduce the potential for new crime, about 25, actually closer to 35 years ago now, a model called the Risk Needs Responsivity Model was developed, and I suspect that many, if not most of you, have heard of this model and know the components to some degree or another. Probably most of you know these particular components of the model, looking at the issue of the risk principle, which is that we should match the intensity of our intervention to their risk of reoffending. That is to say, we don't want to give too little to those folks who are more likely to recidivate, and we don't want to give too much to those folks who are less likely to recidivate. The needs principle is just the other side of the coin. It's basically saying there are certain factors or needs that feed into the person's risk, and that if we don't lower or ameliorate those needs, then that person's risk will not drop. And that we might treat a whole bunch of other things, but that if we don't hit those criminogenic factors, then we will not lower their risk to recidivate. And some of the typical ones, of course, in what's called the Central 8 include antisocial behavior and thinking, antisocial attitudes, substance addiction, criminogenic peers. And the third component in that model is the responsivity principle. Responsivity principle tends to be the most generally, or I should say the least generally understood of the three. It talks about tailoring the intervention to the learning style and the motivation of the individual, the culture of the individual, the abilities of the person, and a variety of other issues that might impact their responsivity, including mental illness. We have gotten fairly good in our field of understanding that from a treatment perspective in terms of responsivity, the cognitive behavioral interventions make the most sense. But generally speaking, we don't do as well at looking at individual responsivity factors. We tend to provide the same programs in the same way to everybody without taking into account the differences between the individuals with whom we're working. The traditional sort of Central 8 that we talk about are here on this slide that looks at static and dynamic risk. Traditionally, we have called criminal history one of the Central 8. but in reality, it's an unchangeable factor, and so it can't really be a need. It's not something we can work on. The things that we can work on and change, you see on the right-hand side here, the antisocial attitudes, the antisocial friends and peers, personality patterns, substance addiction, family and marital factors, education, employment, pro-social leisure activities. One of the things that I'd like to point out to you is that in the early traditional model, substance addiction tended to be toward the bottom, and it was seen as not being an especially strong predictor. More recent research has shown that that was a mistake, basically, and that at least at this point in time, as we look at the data, it needs to be considered to be a much higher issue, a much higher concern, and that in fact it is possible that people won't even have very much of the first three items that you see here in this list, but that their substance addiction issues would be such that their risk of recidivism is higher and their likelihood of failing is increased, so that we need to pay more attention to that. So what you'll see here is we still have 8 items, even though we've moved the static criminal history to the left. And one of the reasons that we have those 8 items is that we broke out education and employment. And in addition to that, we have moved up substance addiction in terms of paying attention to that issue in a much stronger way than historically we have done. When we talk about individual responsivity factors, I mentioned a few of them, but others include, of course, anxiety and ADHD, the level of motivation of the individual, gender of the individual, mental health issues that the individual may be experiencing, substance use issues, which is both a risk factor and a responsivity factor, their comprehension, reading level, English as a second language. We see lots of situations where folks are able to read or repeat what it is that is given to them, but their comprehension of that is not very good, and we don't test very often to look at those issues. And then transportation and housing are other responsivity factors that we don't pay close attention to as a system. We're beginning to understand more and more that without the meeting of those basic needs, the cognitive behavioral work that needs to be done will not be as effective. And that one of the reasons why we are, the good news is that we are now lowering recidivism rates using cognitive behavioral interventions to somewhere between 23 and 28%. The bad news is that still leaves a whole lot of other recidivism that we need to respond to. And we're beginning to understand that it's because we haven't paid enough appropriate attention to issues like mental health, to issues like transportation, housing, and substance use as part of the larger scope of individuals' responsivity issues. Given that, a few years ago, they updated the R&R model. And while I suspect, as I said, that most, if not all of you are familiar with the R&R model, I'm going to guess that much fewer of you are familiar with this expanded R&R model, where you see the things that we typically hear and talk about, risk, need, and responsivity, are here, but they're surrounded by a whole lot of other important things that really make a difference. The first thing has to do with the overarching principles, which really focus on the issue of respect for the person. It's not just what we're delivering, it's how we're delivering it. And the second piece has to do with the issue of the theory or the psychological issue of using cognitive behavioral interventions and social change models in the work that we do with individuals. The third one has to do with the concept of human service, and what they mean by that is providing it in a humane way, in a respectful way. And the fourth has to do with crime prevention, because of course our goal is community safety, our goal is public safety. Then under that, they have the traditional R&R components that, again, I suspect most, if not all of us, are familiar with. And then they talk about the fact that in order to get there, you need to have appropriate structured assessment. And no doubt, most of us are using risk assessment. Many of us talk about it that way. We talk about risk assessment. We don't talk about risk and needs assessment. And even fewer of us tend to talk about strengths assessment. So many of us will give a risk level, but we will not then necessarily determine what are the needs that need to be responded to. Many of us will determine those needs that need to be responded to, but then our case plan will not reflect those needs. And again, fewer of us actually include in either the assessment or the case plan the strengths of that individual. When you move to the next component in terms of program delivery, there's the issue of dosage and how much dosage we should be giving to folks at different levels, which is not something that historically we have paid much attention to. Again, historically, we have a 12-week program, we have a 20-week program, or whatever, but we haven't really thought in terms of how many hours does an individual need if they fall into, say, a lower risk category as opposed to a higher risk category. And in the expanded model, we're paying more and more attention to that. And we have some initial data to support ranges of treatment intervention from between about 50 hours to over 300 hours. And I want to emphasize that at this point, we're talking about initial data. We don't have a lot of data yet, so we're at the early stages of that. And the second thing that I want to point out is that that dosage discussion has to do with correctional intervention, meaning with interventions specifically related to lowering the risk of recidivism. It may be that people have chronic mental health needs that will require very long-term types of involvement and intervention, and the dosage component of the R&R model is not suggesting otherwise, and I do want to be clear about that. The model also has been expanded to look at the issue of how staff interacts with clients in terms of their relationship skills, their ability to develop relationships with clients, and their structuring skills, their ability to be able to structure programming with clients and to interact with them in a way that moves them along a continuum of behavior. Historically, we understood that the model needed to be cognitive behavioral, and we understood there needed to be fidelity to a model in the sense of making sure there were components to that, but we didn't pay as much attention to how we presented that. And so we've seen some very unusual things happen over the years in terms of how that is done. And what happens is that when it's presented in a way that does not connect the individual to the client they are working with, it is much less effective and the outcomes are relatively poor. And then last but not least, in terms of the expanded model, it really looks at how does the organization really build itself around this? How does a corrections department really look at its goal as habilitation and look at everything that it does, whether it's what its COs do, what its caseworkers do, how its wardens behave, and on and on and on. How does that organization really look at all of these components to move somebody from criminal behavior to behaving appropriately? It also talks about the issue of continuity of service from the facility to the community and the development of community linkages. This model is now several years old. It was originally developed about 8 years ago, and what we find is that there are still relatively few places that understand the larger R&R model and are still focusing strictly on the risk need responsivity subset of the model. There are a couple of very good articles explaining this, and we can easily make those sites available to all of you that are on this webinar if you would be interested in looking at those articles. So all of that led us to be thinking about the fact that we needed to have a more integrated way of thinking about how it is that we respond to these issues and to folks that have these issues. And so we spent a good couple of years pulling together a lot of different folks, a lot of different specialists, researchers, national organizations, and came up with this framework that you can download from our website that is titled Adults with Behavioral Health Needs Under Correctional Supervision. And we designed it as sort of being a foundational report for policymakers, for administrators, and for service providers. The goal is to how do we improve the outcomes for those folks who are cycling through the criminal justice system, sometimes again and again and again, who have mental illnesses and substance addictions. Publication's goal is to help policymakers, first of all, develop a shared language around the risk of criminal activity and public health needs. Secondly, to help them think about how to integrate the best practices in mental health treatment, substance use treatment, and recidivism reduction, and how to allocate scarce resources more wisely, because of course we never have enough resources, and often we have a tendency to throw the same things up against the wall, if you will, without necessarily looking at whether the outcome is different after we've done that, and to maximize the impact of those interventions on public safety and public health, because again, at the end of the day, That's what our jobs are about, right? Our jobs are about public safety and public health. But what we know is that in order to improve those things, we need to improve the lives of the individuals that are in the criminal justice system. And in order to do that, we need to both deal with their behavioral health issues and with the risk factors that make them more likely to be involved in some type of criminal behavior. And so the framework looks like this. And what you see are basically 3 levels. What you see are 4 levels, but 3 levels leading to the 4th level. And the first thing that we wanted to look at and that we think is important to be assessed, of course, is the issue of what is the level of risk that the individual presents with. And when I say level of risk, I mean level of criminogenic risk. And we broke that into 2 groups. We broke that into your lower level of criminogenic risk and your medium to high level of criminogenic risk. Now, for those of you that are wondering why did we break it down that way, what we know is that cognitive interventions have an impact for those folks with medium to high levels of criminogenic risk. So those are the folks that you want to provide cognitive interventions to. This is not an assessment tool, so obviously you would be using an assessment tool to further delineate where that person fits and what those needs are. But conceptually, on the left-hand side with low criminogenic risk, what you see are groups of individuals that, regardless of what else I'm about to say underneath it, would be folks that we'd want to have let the criminal justice system less involved in providing certain things to. And those folks on the right, the criminal justice system has to take the lead in assuring that those responses are given to them, including the cognitive behavioral interventions. Underneath that, in the second row, what you see is the area of substance use. And what you see on the left and on the right are the same pair, which is the issue of low severity of substance use or substance dependence. And if you are low criminogenic risk and low severity of substance use, then that puts you in one category. But if you are low criminogenic risk, but you have substance dependence, that puts you in another category, and you can see how that moves on down. On the other side, it's possible to be high criminogenic risk and low substance use or low substance dependence. So in both cases, you could be low or you could be high. So you could be low criminogenic risk with low substance use or high substance dependence, or high criminogenic risk and no substance use or low severity and substance dependence. Then we added the third component, which is the issue of serious mental illness. And it's possible to be low, low, low. So it's possible to have low criminogenic risk, low severity of substance abuse, and low severity of mental illness. And what you'll see is that brings you to group 1. And the simplest way to talk about group 1 is basically this: leave them alone. Do as little as you can in terms of working with them, in terms of getting in their way. These are not folks that you want to give cognitive programming to. They're not folks you want to order into substance use treatment. They're not folks that you want to order into mental health treatment. You want to do the basic or the bare minimum to assure that they get through whatever it is their role is or their sentence is or their time is in the system, whether that's in the community or otherwise, and typically it would be for this group. You want to get them through and out of the system and leave them alone. Now, it's also possible that you would be low criminogenic risk and you would have low severity of substance use, but you would have serious mental illness. And so those are folks that are going to need some help, right, in terms of in terms of mental health treatment. And it's possible that you could have low criminogenic risk and you could have high substance dependence and high serious mental illness or co-occurring disorder, in which case, again, you are going to need some help. But you'll see that groups 2, 3, and 4, they're sort of boxed in a group. The suggestion is this: those are folks that you want to, if they are in your system, you want to make sure they get the appropriate mental health or substance use or co-occurring disorder treatment, but you do not want to give them the cognitive behavioral interventions. You don't need to do that. And you don't want to supervise them as if they're high criminogenic risk. You want to respond to them for what their needs are, which is substance use and or mental illness. And you want to assure that they get those services. You want to get them through the system. You want to get them out of the system. And hopefully those services are being provided by community providers and not under the criminal justice system umbrella, if you will. When we move to the right side of the framework, we're looking at folks who do have medium to high criminogenic risk. And again, they might have low severity of substance use, but they might have some significant mental illness issues. Well, if that is the case, obviously you don't want to provide any substance use treatment, but it is also true that you may need to stabilize them in terms of their mental health needs before you can successfully provide the cognitive behavioral interventions. So you can't simply say, okay, everybody gets the cognitive interventions because they're high risk, without paying attention to whether they have the substance use and or mental health needs. And if they have those needs, you may be able to provide those things at the same time. You may be able to provide those services at the same time. Or you may have to sequence them, and you may have to deal with, for example, the serious substance dependence or serious mental illness issue prior to them being able to be successful in the cognitive programming. What you see here at the bottom here is group 6, 7, and 8, again boxed in. Those are the folks that we would suggest strongly are the folks that indeed the criminal justice system has to take the lead on. Those are folks that have the high criminogenic risk. But we would also strongly argue that the criminal justice system can't solve the problem strictly through the correctional interventions, through the cognitive behavioral interventions, which is why you're going to hear in just a few moments about the development of collaborative case plans and why it's important that even when the criminal justice system needs to take the lead, and even when somebody is a medium to high criminogenic risk, when they have these other behavioral health needs, the collaboration with the appropriate behavioral health providers, substance use, mental health co-occurring providers, is absolutely necessary in order to increase the potential for success. Many people on the right-hand side of this chart, if you will, under the medium to high criminogenic risk, end up failing not because they are high criminogenic risk. They end up failing because the behavioral health needs are not adequately met, and that not adequately meeting them gets in the way of successfully responding to the criminogenic risk. So it's a way of thinking about and integrating what it is that needs to happen. It's a way to think about how to sort, if you will, individuals, not based just on the traditional risk model, but also sort them in terms of what are the kinds of services that they need that are likely to improve or increase their responsivity and make them more successful to the traditional correctional interventions that we provide to those individuals who are moderate to high criminogenic risk. And with that, I will turn it over to our next speaker.
Great. Thank you so much, David, for that overview. So now I'm going to talk about the Collaborative Comprehensive Case Plans tool that David just mentioned and discuss how the Behavioral Health Needs Framework informs that tool. So the Collaborative Comprehensive Case Plans, or CC Case Plans web tool, was launched about 2 years ago in October 2017, and it was developed to serve as a one-stop shop for information on developing and implementing case plans that balance criminogenic risk and behavioral health needs, something that has been a challenge to the field. And it builds upon adults with the behavioral health needs under correctional supervision, which David just discussed. And this tool is designed to apply those macro principles to the micro level of case planning and to make this information practitioner-focused and friendly. So the web tool has a few different parts to it. So the first is this list of 10 priorities and components for case planning, which you can see up here. And each row in the box is expandable, so you can click on each area to read more information about each component and priority, and also to see links to resources for more information. And then this color wheel gives an example of how different agencies can take the lead and how they coordinate with other agencies and other entities in the case planning process. And the most commonly seen lead case planners that we've worked with are community supervision agencies, corrections agencies, and behavioral health treatment providers. And In the color wheel, you can see how the lead case planner sits in the middle, and then the other agencies and entities around that lead are medical behavioral health care, criminal justice focused, social service oriented, and the support system for the participant and the participant themselves. And when you click on each of those different subsections in the color wheel, you'll see examples of information that the lead case planner should share with those entities and vice versa. And so these examples are things that can and should be documented in the case plan to make the case plans as comprehensive as possible. And then finally, the web tool has snapshots of 3 grantee programs under the Second Chance Act CSAMI program, starting with San Joaquin County, California Probation Department, and also Franklin County, Massachusetts Sheriff's Department, and Marin County Bridgeway Recovery Services and Sheriff's Department in Oregon. But each snapshot has basic information about the jurisdiction and the program, and then they focus on 3 key areas for collaborative comprehensive case plans, which are interagency collaboration and information sharing, staff training, and screening and assessment. And so now I will turn things over to Whitney Johnson at the Douglas County, Nebraska Community Mental Health Center, who will talk about her program and their case planning processes.
Hello, everyone, and thank you for having me. Again, I'm Whitney Johnson, Case Manager for Douglas County Intensive Outpatient Program. It is a collaboration between the Douglas County Community Mental Health Center and the Douglas County Department of Corrections. The IOP program was initiated in 2015 through a Second Chance Act grant, and our program is actually housed in community corrections. Community corrections includes work release and the reentry assistance program in Douglas County. The clients here are still incarcerated, but they are allowed to wear their own clothes, schedule doctor's appointments, and eventually apply for work furlough. We focus on the co-occurring high-risk, high-needs population, and all of our therapists are dually licensed for mental health and substance use. Again, I am the case manager. It's something unique to IOP programs in Nebraska. I am the first case manager of an IOP program, and we found that that's helped with that multidisciplinary treatment plan. Clients can work with their individual therapists on their mental health and substance use concerns, then I can handle the resource side of things. Something unique to our program is we also started an IOP support group in the community. This support group is open to graduates of our program, and we've also, through corrections collaboration, have allowed our clients who are halfway through the program to attend this support group as kind of a warm handoff into the community. So when clients get released, they know that they have sober friends and healthy relationships in the community to help get them through that release process. We also encourage graduate peer support. Any of our graduates are welcome to return to community corrections and speak to our group or attend group as peer support. We found that it's been very helpful for especially our clients who are just starting the process to kind of see the light at the end of the tunnel. Our program offers 6 months minimum follow-up services, and what that means is once someone graduates our program and are then released into the community, they have my case management services for free for up to 6 months. So if anyone needs any help, I've helped people with diapers, I've helped people with food and housing and employment and mental health. Any of those needs, I am able to help them. I'll meet them in the community, or they've also come here to see staff and meet with me at my office. I think one of the most important things that our program has done at Community Corrections is create that therapeutic alliance in a correctional environment. It's been interesting to watch behavioral health and corrections meld into one unit. And not only do we create that alliance with our clients, but we also create it with the staff. We are able to support corrections staff by maybe handling some of the behavioral situations that would normally get a client sent back to the secured side of the jail. Our IOP program uses the Matrix model curriculum. It's evidence-based, and it's from the 1990s out of California. The Matrix model addresses basic needs, criminal thinking, anger, hostility, identity issues, resistance, and boundaries, and we help create that therapeutic alliance. The curriculum includes 9 hours of group therapy per week and 1 hour of individual therapy per week. Some clients like individual, some clients like group, but either way, they have to do both. I think one of the best parts of our program is our collaboration with other entities in the community. We work with, obviously, corrections, the court systems. We work with drug and young adult court, veterans court, probation, child protective services, housing, and more. I think one of the most important things is creating those points of contact with each of these entities, because it's easier to set clients up with these resources as you go forward by knowing one person to get a hold of. Looking at information sharing, IOP is substance use and mental health treatment, and therefore we are covered under HIPAA and 42 CFR Part 2. And it's important, if you are going to start any sort of treatment program, to understand your state and local standards for mental health and substance addiction records. In Nebraska, mental health and substance addiction records are different. The laws can change depending on what has passed in legislature, so understanding that is very important. Utilizing our community resources, get those ADMR signed, and making sure that all of the resources have all information that they need to make this client's transition successful. Again, points of contact are very important. I highly suggest team meetings with the client and all of the staff present to make sure that everyone is on the same page with the transition plan. And working with the medical records department to make sure that all information sharing is being done correctly. Before a client comes to IOP, they actually go through a pretty extensive screening and assessment process. When a client is arrested and brought to Douglas County Jail, they are automatically signed up for a screening and assessment process through the reentry specialist at admissions. So what that means is a reentry specialist will come in and meet with the person individually, safety up in the air, making sure everybody's safe in the situation. But they will perform the following risk screens, and I'll detail them a little bit for you. The first risk screen is the proxy, and it helps staff triage the clients into the low, moderate, or high risk categories, kind of talking about those recidivism risk factors and criminogenic factors from before. The second screening is the GAIN short screener. It only takes about 5 minutes and helps the staff identify if the client may have one or more behavioral health disorders. And these can be used to statistically track any behavioral health changes over time in the population, as well as what sort of referrals the staff is making for this client before their release. The PCLC is essentially the shortened version of the PTSD checklist, and it's for civilians. And there is also a military-specific version used for the veteran population at the jail as well. And the Ohio TBI identifies a history of any traumatic brain injury that may need to be addressed while incarcerated. And the staff also documents on any housing, employment, medical, or mental health needs as well. Once a client has gone through all of these screenings, they may be referred for a chemical dependency evaluation if staff has identified that the client has had a history or current issue with substance use. During this chemical dependency evaluation, the practitioner will use the ASI, or the Addiction Severity Index, and they go through problem areas such as medical status, employment, legal status, drug and alcohol use, etc. And the practitioner will also use the SASI-4 to identify whether or not the client has a high or low probability of a substance use disorder. And based on these score totals, the staff member will then refer the client to what level of substance use service they would recommend, which if they came to us, it would have been intensive outpatient treatment. Something that we try to do is prioritize our clients' needs and goals. Our clients come in, they a lot of times are coming off of drugs or alcohol. They are focused on what's going on outside in their families and communities. They're focused on money. They're focused on missing work. And so trying to prioritize the needs and goals of the client to help them not only get through their incarceration, but also make their transition successful. So we develop long-term and short-term goals. Our long-term goals focus on what's life going to be like once you leave. What are the things that we need to accomplish while you're here? And then the short-term goals is, okay, how are we going to do that? What does that look like? We try to use SMART in our goal planning, which means specific, measurable, attainable, relevant, and timely. If it can't be transferable out into the community, then we need to try something else. And most importantly, the needs and goals need to be client-led. If the client is not buying into the process, if the client is having no say in their own goals, then they're not going to buy in and it's not going to be successful. I think an important thing, especially for treatment programs, to do is understand that while we have a curriculum to follow, there are individual needs of the clients that need to be met. Our plans here help identify what factors led to incarceration, enable better follow-up support, and help get positive results. So one thing that we do at the end of our 6-month post-release or graduation date is I go back and I look up if the client has recidivated at all, any charges. I look and see if they have any entries into the criminal justice system. And so far, our success rate for recidivism for any new charges is 88% success rate for that 6-month follow-up period. And that makes us very excited. Thank you very much.
Great, thank you, Whitney. So now I will turn things over to Donna Bond in Oklahoma to talk about their program and their case planning processes.
Hello, my name is Donna Bond. I am the coordinator of mental health reentry for the Oklahoma Department of Corrections. First of all, I just want to say how much I appreciate being included in this webinar and the ability to share what we're doing in Oklahoma. Initially, in 2007, through legislative appropriations, we were able to initially hire 3 integrated services discharge managers to work in the correctional facilities with the mental health unit. Since then, 13 years later, we have grown. There are now 6 staff that are employees of the Oklahoma Department of Mental Health and Substance Services that work inside correctional facilities that have the highest numbers of inmates with mental health, serious mental illness, and also co-occurring disorders. We focus on our interventions with people with the highest risk, highest needs, and I'm going to use discharge managers instead of the ISDMs. It's just a lot easier to say. But the discharge managers engage with people who have serious mental illness. Best case scenario, starting 1 year before they're released from prison. Sometimes we don't get a year, but that is our goal. One critical piece of what we have built and what we're doing through this collaboration is we use evidence-based assessment, including the level of service inventory, the LSIR, the Adult Substance Abuse Service Survey, which is the ACES, the Ohio Risk Assessment System, which is the ORAS. We use the reentry piece before discharge, and the community piece is used once the inmate discharges to the community provider. We evidence-based practices also in the community, motivational interviewing, that includes stages of change, and cognitive behavioral intervention. The interagency collaboration includes the Oklahoma Department of Corrections and the Oklahoma Department of Mental Health and Substance Abuse Services. The discharge managers act as the lead case planner. They access participants' needs, and this includes housing, employment, public benefits, disability and Medicaid or Medicare. This also may include legal aid for family reunification. It can include linking inmates who have discharged to medical care and anything that falls under the umbrella of a need that the participants have. We have a partnership or linkage to provide that. We start our process as far as getting public benefits approved. We start this process at least 6 months to a year in advance, but as far as our Social Security, disability, and Medicaid, we have a timeline that we must follow through our Memorandum of Understanding and our agreements with Social Security Administration and Disability Determination Division that at 120 days pre-release, we will start the process. If we start any earlier, then, and if they don't release within that 120 days, sometimes those will automatically be denied. So it's very important to work with the prison system and make sure that we've got the projected discharge date correct, and we're working on that timeline. We do target inmates that have the highest risk, the highest needs, using the Ohio Risk Assessment System. We use this while they're incarcerated in the prisons, and we also do the assessment, the community-based assessment, at 6 months post-release from prison. We have 4 contracts in the community that are called RICIT, and this is Reentry Intensive Care Coordination Team, acronym RICIT, and these contracts have team members that come out into the community. They are from the 2 largest cities in Oklahoma, including Tulsa and Oklahoma City. Once they start the initial assessment and they approve someone for their program, they're required to do monthly in-reach visits to build rapport and just to build that relationship. And we have found that in-reach really makes a stronger connection, and we have a correlation with success in the community, longer engagement, more often, with more in-reach in the prisons on the front end. These teams are trained and use strengths-based case management assessment tools. They use motivational interviewing. They want to make sure that everything is client or consumer driven. Of course, when they're starting in the prison, I guess we'd say inmate driven, but we want to stick with the consumer driven and consumer based plan. Each RICIT team consists of a certified case manager, a licensed behavioral health provider, and a peer recovery support specialist. Over the past 13 years, we've been doing the collaboration with RICIT. We've had recidivism rates that have decreased 50% compared to the baseline group for the first 3-year outcome study. We've also had increase in inpatient admissions, increase in engagement in outpatient services, and many other outcomes, too many really to list in the time that we have, but just a lot of success. Also, in this 3-year or 13-year time period since we started our program, we've been able to apply for and be awarded federal grants through SAMHSA and also through the Second Chance Act, BJA, with Council of State Government working with us as our technical assistant in that way. So we've really grown since our original start date and our original collaboration. We've not only grown in our prison-based staff, but we've also grown in a lot of lessons learned throughout this time. We use probation officers that have specific experience with mental health and substance abuse services, and we have found that to add a lot of success to our programs as well. I think that about wraps up what I want to talk about Oklahoma, but I am open to any questions that I may have overlooked or left out.
Great. Thank you so much for that, Donna. So now we have a bit of time for questions and answers, and we've had a few come in already. I'll remind attendees on the webinar, if you have a question, feel free to type it into the chat box, and then we'll try to get to your questions as we go. One question that came in already is, in pretrial services, risk assessment might only include static factors. Are there creative ways of assessing an individual's dynamic risk factors at the pretrial stage, even if the assessment instrument in use doesn't include dynamic risk factors? I think I'll have David start this off and then Whitney chime in, because I think most, if not all, folks in IOP were pretrial.
Hi, Mark. I was actually just typing a response to that individual, as a matter of fact, around that question. And part of it depends on what you mean by looking at dynamic factors. When we look at some of the dynamic risk factors that are considered, such as employment or marital status or stress in family or other contact with the criminal justice system or current contact with the system, they actually have not been proven to be particularly powerful predictors of pretrial problems occurring. However, when you look at issues of, not surprisingly, mental health and substance use as dynamic factors, they in fact have been shown to be relevant. And I think, as one of our other speakers was talking about, doing a screen, doing a mental health screen, doing a substance use screen, in addition to a traditional pretrial risk screen, makes a lot of sense. And if somebody has both sort of a high potential in terms of their pretrial score and has significant issue in terms of substance use and or mental health, you're going to want to target those two things with some targeted treatment in terms of the potential for improving their success. But in terms of adding a bunch of dynamic criminogenic risk factors at the pretrial level, we really don't have data to support that happening in any consistent fashion. We don't have a validated tool that does that. When we start looking at the individual items, the potential for bias gets pretty significant. So when I say dynamic factors, I'm really thinking about those dynamic factors of mental health and substance use need in particular.
Thanks, David. And then Whitney, do you want to jump on that question at all?
Yeah, sure. I would say about 97% of our clients are pretrial, and so part of what we like to do with them, again, with that treatment planning process, is looking at those long-term goals and say, hey, what went wrong in the beginning? What are those risk factors that we need to switch up for when you leave? Like David said, I don't think there's necessarily an evidence-based way to go about this, but we just kind of do what works, looking at especially education, employment, housing, basic needs, any mental health or medical appointments that need to be made. We try and address all of those things.
Great, thank you. And another question we have is, and this one's for Donna, was there a process for getting the local government or state to approve starting a client's benefits application or reactivation? Was there an MOU involved?
Yes. Yes. We have MOUs in place with both the Social Security Administration, with several local offices in Oklahoma, as well as the Disability Determination Division, also with the vocational rehab. But I would like to mention something that I didn't mention earlier on. This collaboration actually started through a SAMHSA study called Establishing and Maintaining Medicaid Eligibility Upon Release from Public Institutions. It was a Mathematica study through SAMHSA, and that is how we actually got started. And we had legislative appropriations that allowed us to hire the first 3 discharge managers and get started. Since then, we've had funding through Department of Mental Health and Substance Abuse Services for the past, following that initial 6-month legislative funding. They have had us in their general budget. So, but yes, there are several MOUs and even information sharing agreements we have with the Disability Determination Division. That way, when we're doing these applications inside the prison, there are a few designated people within the DDS that can also go into our medical record system and pull information that maybe was left out of the original application that was done by our SOAR-trained people in Oklahoma that do these applications.
Great, thank you, Donna. And then a related question is, are there examples of MOUs between corrections and behavioral health agencies that can be shared? This one's for Donna and for Whitney.
Can you repeat the last part of that question?
Yeah, so the question is, are there examples of MOUs between corrections and behavioral health agencies that can be shared?
I don't know about sharing them. We definitely have MOUs, contracts and MOUs in place. I wouldn't be able to say that, anything. I wouldn't be able to speak on the topic of what we can share and what we can't, but we do have those. I mean, that's something that we could look into.
Okay. And then, Whitney, did you have any thoughts on that question?
As in other agencies aside from what we're doing?
Yeah.
Oh, yes. So there's the collaboration with Community Mental Health Center and Douglas County Corrections. There's also an MOU with 2 of our homeless shelters that also have treatment programs. And they have staff that come in and do other cognitive behavioral programming in the jail as well.
Great. And are those MOUs shareable?
I believe so. I would have to get a hold of them.
Okay, great. And then another question we have is, in terms of rolling out standardized assessments and screenings, where and when do you do interviews and who does them? And so this question comes from someone who's a manager in a behavioral health treatment court and their staff uses the ASAM, but in open court due to the volume in court. And so they're looking for suggestions of when and where the screens and assessments take place.
I can speak for Douglas County then. So like I said, when a client or an inmate first comes in, a reentry specialist is assigned to them. There are a total of 8 reentry specialists in Douglas County Jail right now, and they serve the 1,350 clients in there. So this person will come and meet with each individual client and do an intake to do all of those screens that I mentioned and assess those needs and start the referral processes that need to happen. And so that's right when they come in. So sometimes it's successful and sometimes it's not, based on how the client is doing at that time.
Great. And then Donna, do you want to add on to that?
Well, we do all of our initial assessments when, in the prison system, and that is when they are all within a year or less of discharge. So, our timeline for doing these and where we do these assessments for our program that we started several years ago, as well as our most recent cricket grant. All of these have been done inside the facilities, and they're done usually, we have common areas, day rooms, different places that we can go inside the prison.
Great, thank you. And another question we have is, when are the family members engaged in the reentry process, especially for those with severe mental illness or behavioral health needs?
I would like to say that from being involved in this as one of the first of the 3 hired discharge managers from the Oklahoma State Penitentiary, which is the maximum security, and at that time had the maximum security mental health unit. It's sad to say that we don't seem to be able to find a lot of willing family members that want to be involved or that are involved. Of course, that is the first thing that we do assess for and that we do look for in the records, as well as in our interviewing process, is because we know that inmates do better if they do have that family support system in the community. But we have found, at least in Oklahoma, that those are very few and far between. It seems like a lot of times they are no longer in contact with family or removed from biological family early on, or just, different scenarios that we don't find a lot of family support with the serious mentally ill population. I think we do find more family support with other populations inside DOC, but with this specific population, from my experience, there's just not a lot of family involvement. But we are thrilled when we can find family involvement. I mean, that is definitely the gold, the gold star kind of. If we have a supportive family that's able and wants to be involved in this discharge planning process, that's just great. But it's not. We don't find it very often.
Thanks, Donna. And then Whitney, do you want to talk about family engagement in your program?
Absolutely. I think we are blessed because we are in community corrections, and so we are able to have the family members actually come in for family sessions. We always give that option to our clients after about 4 or 5 weeks in the program while they're working on themselves, and then we can contact family members and have them come in. I would also echo what Donna said. A lot of the times those family connections have been severed, and so whether or not it's on the client's treatment plan or not, our goal is to try and reestablish those healthy family connections if we can. We try and, from the very beginning at that first intake, get releases of information for family members, especially for the SPMI, severely mentally ill population, to get as much history as we can on the individual, and then hopefully contact any current doctors and Social Security and all of those entities.
Great, thank you. And another question we have, and this one's for David, is what are some recommended cognitive interventions for addressing the top criminogenic needs?
So there are a number of programs out there. The most common ones that you see utilized in the community are, one is called Reasoning and Rehabilitation, or R&R, and it has both a short form and a long form. Another equally common one is MRT, or moral recognition therapy. In fact, it may be, at the moment, it may be the most widely used in the community. Historically, there was also a program called Thinking for a Change, which was something that was able to be used both in institutions and in prisons and in the community, but its most recent iteration was developed so it specifically can only be used in jails or prisons, and so it's not something that you see as much of in the community anymore. There are still a number of community agencies that are using version 3, if I recall. Version 4 is what is out now. Those are the sort of the three most common brand name ones. There are also some anger management programs out there that folks use as well. But in terms of sort of general responses for criminogenic risk, those would be the three most commonly used ones, or the three most commonly named brand ones that are out there. It should be also, it would be important to also know that there are a number of studies out there that show that you don't have to use name brand programs, that you can use cognitive models and cognitive interventions that are developed based on using research-supported components. In other words, you don't have to always buy a name brand program. We will be happy to post for folks along with this a link to an article by Lipsy that is a meta-analysis of looking at cognitive behavioral programming and interventions that can help you take a look at both whether it makes sense to purchase a name brand program, or whether, if you don't have the ability from a fiscal perspective to do that, if you don't have that ability, what are the other options that you can use to develop a cognitive behavioral program intervention for your clients.
Thank you, David. And another question we have is, can you discuss how staff were trained in case planning? And this one's for Donna and for Whitney.
Can you repeat that question? I'm sorry, Mark.
Yes, no problem. The question is, can you discuss how staff were trained in case planning?
Well, as far as speaking for what our collaboration in Oklahoma, starting in 2007, we, with the first 3 discharge managers, we went to so many different training, different models of, just like I said, strength-based, motivational interview training. We went to, I'm just trying to think of them off the top of my head. The RAP model, which is maybe not be as relevant with this question, but we've had several really well-renowned trainers come into Oklahoma over the past 13 years and do a lot of training with us. A lot of trauma-informed case planning training, just the gamut. It's really just too much to go back and think of. We had more in the earlier years starting out than we've had recently, but we have had a lot of training in this area.
Great. And then Whitney, do you want to talk about training for staff at your program?
Absolutely. All staff in our programs are required to go through non-crisis prevention training through CPI, so de-escalation skills. And then we are also signed up for Mental Health First Aid USA as part of our training process. I think a lot of our local agencies will put together different programs and different presentations that we are encouraged to go to and are given the time to go to. As far as case planning itself, we sit down regularly and talk about what are the barriers that we are seeing the most, and then how do we help these clients overcome these barriers? What connections do we have to make? What sort of alliances do we have to create in the community? So again, working with your other agencies that you're collaborating with and kind of getting those core pieces together will be important for your client's success.
If I could just kind of interject something too, after Whitney started talking, we have definitely had the mental health first aid, the CIT, the CCIT. So when she started talking, some of these things kind of came back to me as well. So, and I have to echo what she says about, all of these different trainings, although they may not fall under the exact description of case planning, these are all things that help with case planning. All of this training, even trauma-informed, we've had seeking safety, basic training, just anything that has to, that can assist this population. Training that we've had is going to go into that case planning because it's so comprehensive, and we want to address any and all needs that they have, that they present with when we start working with them, and they're all very unique. So I just wanted to interject that.
Yeah, exactly. Thank you for adding that. Well, in the interest of time, we had some great questions come in, but I want to make sure that I do a little bit of wrap up. But the panelists would be happy to follow up by email for additional questions or thoughts that the attendees have. And so here are links to the adults with behavioral health needs under Correctional Supervision framework that David discussed, and then the Collaborative Comprehensive Case Plans web tool that I discussed on the webinar today. And then here is contact information for the panelists today, and they'd be happy to follow up with additional questions you might have after the webinar. And then that brings us to the end of the webinar today, and I want to extend a special thank you to the panelists for joining, and thank you to everyone who attended the webinar today. We recorded the webinar, and we will post it on the National Reentry Resource Center website within a week. And also, as a reminder, you can sign up for National Reentry Resource Center newsletters to receive information about upcoming webinars, funding opportunities, and news in the field of reentry. Thanks again, everyone, for joining, and have a great afternoon.